Thank you for joining us today for our webinar on cow's milk allergy, a closer look at development and prevention in infancy. I am Jennifer Gertz, Executive Director of Food Allergy Canada, and our guest speaker today is Dr. Edmond Chan. Before we get started, just a few items to note. Note that this session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. All participants are muted so we can keep the audio clear for the webinar. This webinar will be recorded and shared on foodallergycanada.ca afterwards. And lastly, we'd like to thank everyone who submitted questions on registrations. There are some common questions that we will tackle in today's session. If you have additional questions during the session, please submit them in the chat question box throughout the webinar, and we'll try to get to as many of those questions as we can. Now, a little background context for today's session. This session focuses on the prevention of cow's milk allergy in infancy and bringing forth the evidence that helps us understand how cow's milk allergy can develop in some infants and how it can be prevented. I'd like to acknowledge from the outset that our organization supports breastfeeding and endorses the Canadian Paediatric Society's position that breastfeeding should be protected, promoted, and supported. We also recognize that there may be circumstances where exclusive breastfeeding may not be an option, and it's in this light that we've invited Dr. Edmond Chan to walk us through the research that provides new insights on the development and prevention of cow's milk allergy and how cow's milk formula factors into this picture. So why have we chosen to dedicate an entire webinar to this subject? Well, today, over 1.1% of Canadians, and that's 386,000 Canadians, live with an IgE-mediated allergy to cow's milk. Milk allergy is the most burdensome one of a multi-food allergic child, and it's tough to manage given the ubiquity of milk and dairy ingredients in food, public confusion between allergy and intolerance, and the fact that milk is a common ingredient in foods that you just can't see. For food manufacturers, and in some specific categories like dark chocolate, cookies, and snack foods, it can be a challenging allergen to manage. In 2022 alone, milk represented about 2/3 of our allergy alerts that we sent out on food recalls that we sent to everyone in the community. And lastly, it's one of the leading causes of food allergy fatalities. So sharing insights that could prevent this possibility is paramount, and it's in that spirit that we bring you this webinar. This session will cover 4 areas. First, starting with setting the context and defining cow's milk allergy, getting clear on the terminology. Secondly, on the guidance around preventing food allergy in babies, then moving to the latest evidence on what to do when cow's milk formula is introduced, and leaving with some practical strategies for families on cow's milk introduction for prevention. We'll have our expert walk us through some slides, and we'll follow that with a Q&A, which will be a combination of submitted questions and the ones submitted through the chat function. Now I'd like to introduce Dr. Edmond Chan. Dr. Chan is a pediatric allergist at BC Children's Hospital Allergy Clinic, UBC Clinical Professor, Clinical Investigator of the Research Institute, and head of the Division of Allergy and Immunology at UBC, where he leads a food allergy research program. He is Vice President of the Canadian Society of Allergy and Clinical Immunology, on the executive of the Canadian Paediatric Society's Allergy Section, and on Food Allergy Canada's Healthcare Advisory Board, and also a steering committee member for Canada's National Food Allergy Action Plan. We'd really like to thank you, Dr. Chan, for taking time out of your busy schedule to be with us today. I'll turn it over to you.
Okay, thank you very much, Jennifer, for that kind introduction. Thank you to Food Allergy Canada for inviting me to speak at this webinar. Thank you for all the assistance of Joni and Ranjit in leading up to this webinar. So it's a pleasure to come and speak to you today about cow's milk allergy, which has been a topic that I've been quite concerned about for quite a long time, as I'll illustrate. And what we'll look at is a closer look at development and prevention in infancy. So yeah, the timing is really very good for doing this webinar because of recent research findings. So with that, these are my disclosures, the most relevant being on the Canadian Paediatric Society and the Canadian Society of Allergy and Clinical Immunology food allergy prevention position statements, being the co-lead, and also being on the Healthcare Advisory Board of Food Allergy Canada. So the objectives are, as Jennifer alluded to, threefold. Look at the current landscape for cow's milk allergy. Look at recent research and guidelines on cow's milk allergy prevention, and then propose some real-world practical strategies for cow's milk protein allergy prevention. So objective number one, current landscape. What is the definition of cow's milk allergy and why is it so confusing? It's because there's really different immune responses that can occur to cow's milk protein. And so in blue there is the focus of today's talk, when you have production of cow's milk specific IgE antibody against the cow's milk proteins. And that results in an immediate type of reaction, immediate hypersensitivity. For example, as something at the more severe end would be anaphylaxis. That is to be contrasted with allergic responses that are more delayed. And so there are conditions such as eosinophilic esophagitis, where there's a mixed picture. Those patients have a combination of delayed responses, and they can also have immediate responses to certain foods. And then a condition such as food protein-induced enterocolitis, or FPIES, where there's delayed responses mediated by T cells or non-IgE mediated responses. And so all of those can be under the umbrella of cow's milk allergy, but what is most life-threatening is the immediate IgE-mediated type. The other term that's confusing is food intolerance, but that simply means that it does not involve the immune system. So good examples for cow's milk are things like lactose intolerance, where you're missing in your gut the lactase enzyme, and a psychologic or food aversion type of response can occur with any food. So hopefully that narrows down in your mind what we're focusing on today. The management of the IgE-mediated food allergy is very specific, and it involves firstly recognizing symptoms. And so the World Allergy Organization has updated their diagnostic criteria, as you can see here, and have two criteria that define anaphylaxis. The first being an acute illness within minutes to several hours, usually up to 2 hours, where you have skin symptoms, either hives or swelling, plus at least one of respiratory compromise, reduced blood pressure, or, and this is where a big change occurred, severe gastrointestinal symptoms, so such as repetitive vomiting. If it's just mild abdominal pain, it shouldn't qualify for anaphylaxis according to the new criteria. The other main criteria would be acute onset of hypotension or bronchospasm or laryngeal involvement after exposure to a known or highly probable allergen for that patient. And that is also relatively new criteria with the WAO. So this is what defines anaphylaxis. You can have milder reactions involving, for example, one of those systems in a less severe fashion. In terms of anaphylaxis management, which would be the subject of another lecture, really it's very clear that we take care of the ABCs, the airway, breathing, circulation first, and then immediately after we call for help, inject epinephrine. Very important in all these guidelines that epinephrine is given as soon as possible, which is why an auto-injector is needed for patients diagnosed with food allergy. And then it goes through some of the other interventions, such as lying on the back with the legs elevated to increase circulation. And then you're moving on to measures such as oxygen, IV fluids, and other measures. So hopefully that narrows our focus on IgE-mediated food allergy. Now, looking at some aspects of this landscape that are pertinent for why cow's milk allergy prevention is important, one point that's really striking me at this moment is that outgrowing cow's milk allergy, according to more recent research, is more difficult than previously thought. So this is a paper just published last year out of Dr. Ruchi Gupta's group in Chicago. And it was a survey of almost 80,000 individuals across the entire United States from a few years ago, all 50 states. And in the left panel, you can see the difference in outgrowing between male and female patients, individuals, where it appears, taking a step back, that females, for whatever reason, are having a harder time outgrowing their cow's milk allergy. So if you look, for example, at convincing cow's milk allergy, you have, a high point in young childhood that does not go down to zero by any stretch, even when you're in school age. And then once you reach young adulthood, according to this data, there's a spike. And so even during the teenage years, not all are outgrowing, and then you get this spike later on in adulthood. On the right panel, I've focused in on their definition of convincing milk allergy. They had very stringent criteria for diagnosing that, such as immediate symptoms like the ones I just described. They also had physician-confirmed milk allergy, and they described that we shouldn't, say that the physician-confirmed is necessarily more accurate than the convincing, because some of these convincing individuals may not have been referred to a physician for confirmation, or may not have seen a physician for confirmation. But what you're seeing from the right panel is a very similar concept, in that you have, a significant proportion of individuals who are not outgrowing their cow's milk allergy. So let's say you start in childhood, in the younger years, at a 1 to 2% type of percentage. Then as you go through adulthood, there's still a lot of adults that are hanging on to their childhood onset cow's milk allergy. When they looked at some of the specific variables that would predict difficulty outgrowing cow's milk allergy in this study, it was very interesting as well that they found that non-Hispanic, Black, Hispanic, and those in basically minority ethnic groups had more difficulty outgrowing cow's milk allergy. Again, as shown in the previous slide, females were less likely to outgrow. And importantly, which is a clinical observation those of us who are allergists make very regularly, that those who have milder reactions at baseline are more likely to outgrow, whereas those who have more severe reactions, such as, for example, cardiovascular symptoms, are less likely to outgrow their cow's milk allergy. And it's that subpopulation that we as allergists worry about the most when we see them in clinic. They're the ones who can react to just the tiniest amount of cow's milk protein, so they have a low threshold. And then when they have their reactions, it's disproportionately meeting the WAO criteria for anaphylaxis. And there's even a subset that have more severe anaphylaxis. So within those that meet criteria, you also have more mild, moderate, and severe anaphylaxis. So difficulty outgrowing. The other thing that is continuing to be striking about cow's milk allergy is its effect on food anaphylaxis deaths. And the best data in the world, perhaps, is from the UK. And this was just published a couple of years ago from Paul Turner and colleagues in the BMJ, where they looked at national hospital data from the UK for admissions and fatalities in 2 decades, from 1998 to 2018. they were able to describe 152 deaths in the UK, so that's a population of over 60 million in those 2 decades, where they felt upon doing this study that the fatality was probably caused by food. And when they looked at the age stratification, they found that cow's milk was responsible for 26% of the deaths in school-aged children. And so you can see it a little bit here in this part of the slide, key allergens. When you look at the children, cow's milk is purple and the pink is unknown. So of the known food triggers, cow's milk is the biggest percentage by far. And you would think it should be peanut, but it's not. So in children, peanut is a smaller percentage. When you get to adulthood, then it's flipped. So then you have tree nuts especially, and peanut taking the lion's share of the cause, and the cow's milk thankfully decreasing at that stage. But where we're really worried is with the school-aged children and even potentially the adolescents. And so the take-home message from this study is that in those with persistent cow's milk allergy, and I just described in the previous slides that we're seeing more and more persistent cow's milk allergy according to our clinical experience and according to the research, that in those individuals that are hanging on to their cow's milk allergy, it's responsible for more than 1/4 of deaths caused by food anaphylaxis. Some of you in the audience may know this, but I have to tell you, most non-allergists are completely unaware of this statistic, and only certain individuals in the general population are aware of this. And this is again why this topic is so important, and it's unfortunate that this topic of cow's milk allergy prevention has really not been discussed openly to hardly any extent at all in the community. Now, continuing with this study, when we look at the age distribution of food-induced anaphylaxis fatalities, again, this slide hones in on how in the adolescent age group and the young adult age group, that's where you have the highest proportion of food-induced fatalities. So how can we use this information? Well, basically, we have to put ourselves in the shoes of the family who now has an infant diagnosed with cow's milk allergy, may or may not know if going to outgrow, and if you're like especially an ethnic minority, or if you're female, and so on and so forth, you're probably not going to outgrow. And then what you're facing is this prospect of all those years from infancy through to age 10, when you're in fear. You're living in fear that you're going to hit the age of 10, and all of a sudden, your risk of having a severe anaphylactic reaction that may or may not result in a fatality increases. And of course, the overall number of deaths in the entire population is small, but it's just that cow's milk is disproportionately accounting for a higher proportion of them. Now, other aspects in terms of the current landscape are that it's expensive to live with food allergy. So we looked at a comparison in my research group of doing peanut oral immunotherapy and comparing costs of that for the preschool peanut oral immunotherapy with living with food allergy without OIT. And although there is a cost savings with early preschool oral immunotherapy when delivered in the way that we deliver it in Canada typically, which is through a public healthcare system, it is cost effective, but it's still a substantial cost to society. And not to mention then that OIT is not the answer for everyone, partly because some may not want it, but partly because even when you want it, access is highly variable in Canada. And so our group did a survey of allergists across Canada, and there were about half of the respondents that were offering OIT currently. But very interesting, when you look at OIT to peanut, you have a lot of these respondents who are offering OIT offering peanut OIT both in academic centers and in the community centers. But when you look at cow's milk, for example, you have, not even all academic centers offering it, perhaps 70% of the responding academic centers offering it. There's a lot of academic centers that didn't even fill out our survey, by the way. And then you have the community practitioners hardly ever offering cow's milk OIT. And that's partly because, as those of you who have experienced it or who have been part of it know, cow's milk OIT is not easy, and it has to do with how cow's milk allergy can be quite severe, as I've alluded to in the previous slides. So that's the landscape. Now let's look at some research evidence and guidance for cow's milk allergy prevention and how it's evolved over the past decade. So this study, I still remember very clearly when it was published. The CBC covered it right away and other media outlets, and I was just so impressed by this study because of the size of the study. So this was a study out of Israel, which was a prospective cohort study. I quite often like to call this the CAT study after the first author. But they followed 13,000 standard risk infants, which is mind-blowing. And then they followed them every 2 months until the infants first consumed cow's milk protein. And if there was a suspicion of cow's milk allergy, then they would have physician confirmation, including skin prick testing and of course history. And then a high proportion of them had confirmatory oral food challenges. And so to me, this was really strong evidence. And their finding was that if cow's milk protein was started in the first 2 weeks of life, 0 to 14 days, and continued, so not stopped, but continued one meal at least once daily thereafter, you ended up with essentially 0 cow's milk allergy, almost 0. That's that tiny green bar that you can't even see. In contrast, for the families that chose to wait until, let's say, this red bar, 120 days before introducing cow's milk protein, and so that'll jive with some of the data I'll show you later on when families start to do mixed feeding. But let's say at 120 days of life, 4 months of life, you start doing mixed feeding. By then, your risk of cow's milk allergy in this study increased to 1.75%. And so really, it was telling us something that feeding early, eating often, not just applied to peanut, because the LEAP study was already underway at that point, but it could also apply to cow's milk protein, but just at an earlier time point, because you don't start peanut protein at 0 to 14 days unless in the future we can somehow mix it with liquid feeding. But here we just have the same things, eating early and eating often at an earlier time point. So that was 2010, and that's just paints the picture of how long this issue has been on our minds for some of us. We couldn't do anything about that because we published our 2013 CPS guidelines, and we couldn't do anything about that CAT study because it wasn't an interventional trial. It was only a cohort or observational trial. And therefore, guidelines need to have interventional trials in order to change practice. That's just the way guidelines are developed. And so we couldn't do anything about the CAT study. And meanwhile, we continue to see, on a daily, weekly basis, these infants who develop cow's milk allergy. And you take the history and, oh yeah, quite often they were given a couple of bottles of cow's milk formula after delivery and then exclusively breastfed after. Or, once a month they're given some formula because, parents go traveling somewhere or go out somewhere. And then, okay, bang, they start yogurt and then they have a reaction. So we couldn't do anything about it. Then we were working on, finally, an update to the 2013 guidelines or position statement. And just before we published that, then the SPADE study out of Japan was published. And finally, this was a more robust interventional trial. It was a randomized trial where they had two arms, roughly 250 infants in each arm, standard risk infants, again, not high risk infants, standard risk. And you had one arm where they were, both arms, they were initially breastfed. They could have been given cow's milk formula up to the families. But then you had one arm after the 1 month of age time point where they were breastfed, plus they had to have at least 10 mLs of cow's milk formula per day. And the other arm, the quote unquote avoidance arm, where they were predominantly just breastfed. And then they continued that style of feeding until 3 months of age. And then they did whatever they wanted. And then at 6 months of age, they did an oral food challenge. And so kind of a complex design, not necessarily reflective of the real world, but in any event, what it illustrated was a very striking difference in that this group that had that regular small volume cow's milk protein between 1 to 3 months of age had very little cow's milk allergy at 6 months, only 0.8%. Whereas this other group had 7% risk of cow's milk allergy, which is staggering. You know, when Jennifer said, oh, 1 point something percent in general population, these are actually general population standard risk infants. And so why were they so high? The hypothesis would be that probably a significant chunk of them were given cow's milk formula between 5 days and, you know, between birth and 1 month of age. And then in this avoidance group, they were sort of suggested, you know, they were actually told to avoid cow's milk protein. And during that avoidance phase of 2 months, that's when their immune system started going overtime and developing the cow's milk allergy. And so you ended up with a risk ratio of 0.12, staggering. Now, for those who feel that, you know, this strategy of 10 mLs cow's milk formula a day would compete with breastfeeding, it didn't, because both the avoidance group and the ingestion group, 70% of infants in both groups were still breastfeeding at 6 months. And so this study, quite staggering risk ratio, it allowed us to change our guidelines to become the first guideline in the world, just because of the timing of when it was published and when our guideline was published, the first allergy prevention guideline in the world to say that when cow's milk protein formula has been introduced in an infant's diet, make sure that regular ingestion, as little as 10 mLs a day, is maintained to prevent loss of tolerance. Of course, the guideline continued to say that what's even better is to promote and support breastfeeding for up to 2 years and beyond, regardless of whether it prevents food allergy or not. When you do a systematic review of it, it doesn't. There's no convincing evidence that breastfeeding prevents, you know, any allergic condition, but it doesn't increase risk. And there's so many benefits to breastfeeding that it really should, for sure, be promoted and supported. The rest of the guidelines, you know, it's mainly emphasizing the eat early often message. You know, for example, non-choking peanut, starting at around 6 months, but not before 4 months, and then giving regularly thereafter, for example, a few times a week. And then screening for food allergies is not recommended in Canada. And so, you know, this we were reasonably pleased with in many ways, because it finally updated the 2013 one, where you couldn't even at that point say that you should start peanut non-choking at around 6 months, but not before 4 months. Now, of course, this message is always going to be controversial because of the breastfeeding aspect. And so just a couple of months ago, so the way that these guidelines are approved is you have a lot of committees and different organizations that have to do peer review. And so interestingly, when the SPADE study was published, that message to keep giving 10 mLs at least a day was requested by the dietitians of Canada. And so we, as the principal authors, were like, okay, that's reasonable. So you want to reflect exactly what the SPADE study did in their methodology? Fine, we'll write it that way. But then a couple months ago, the Nutrition and GI Committee of the Canadian Paediatric Society said, we kind of prefer the version that you had drafted before the final document, which said that intermittent supplementation with cow's milk formula, for example, a few bottles in the hospital followed by exclusive breastfeeding, should be avoided due to increased risk of cow's milk allergy. So it's really just putting the corollary of what was originally in the position statement. And then we as the authors were like, oh yeah, that's good too. In fact, that was the original terminology we had in the draft. And so just in the past couple months, the CPS version has flipped back to our original terminology. Again, we're happy with either, but we agree with Nutrition GI that now we see less of a need to reflect the exact terminology of the SPADE study. And why is that? It's because why have we positioned this webinar today to be timed, the way it has been? It's because this study was just published in final form this month. It was in press in the past few months, and it really removes the need to put a message that's confusing like 10 mLs of formula a day. This is the COMET study out of Israel, which is the highest level evidence in the world to date on cow's milk allergy prevention. It's the largest interventional. Remember I said earlier, guidelines need interventional trial results. And so it's an interventional trial where in Israel, they recruited almost 2,000. Again, a theme of these studies is standard risk. So they didn't have an elevated family history of atopy. They were the general population risk. So standard risk newborns, 2,000 of them recruited shortly before birth, and they were recruited into two groups. It was unethical to force them into, randomize them into these two groups. So it was their choice. They could either do the breastfeeding group, or they could do at least one daily meal of cow's milk formula group. And these groups were followed for a duration of 12 months. And they were followed at regular intervals to see if they would develop cow's milk allergy. And so the primary outcome was, and this is why I've color-coded the results here to, as best as I could, match the graphs here, which I'll go through with you because it's a little bit tedious. So in this panel A, we have the overall breastfeeding group in blue color, and we have the at least one bottle a day of formula group in the darker green. And the darker green is comprised of those who have cow's milk formula as their only form of feeding, and those who have mixed feeding over here. When you compare the blue with the dark green, the relative risk was almost 30 for development of cow's milk allergy in the blue versus the green. So 1.58% of the blue developed cow's milk allergy versus 0% in the green. And to make it simple, basically green, anytime you see it, is 0. If you were getting cow's milk formula every day, in all these comparisons, there was 0 cow's milk allergy. Now, let's dig deeper for the blue. You can stratify the blue into what we call per protocol, which is this sort of medium blue here, versus protocol deviations, which is the purple here. The protocol deviation purple is comprised of exactly that clinical scenario I see in clinic all the time, where the first 48 hours, they're given a few bottles of formula, and then it's exclusive breastfeeding every single day until something like yogurt is given at 6 months, okay? So that's a big chunk of the purple. Then you have, those who in the first several months of life are given up to 5 bottles of cow's milk formula intermittently. There are those who have random exposures. There are those who switch around, and those are those who are unknown. All of that are protocol deviations. When you compare this protocol deviation group, where they have largely breastfeeding, but a few bottles of cow's milk formula here and there, it's the most staggering. It's a relative risk of 62. So 60 times the risk of cow's milk allergy for that mixed feeding group compared to the regular feeding group. 3.27% in these standard risk infants of cow's milk allergy in that mixed feeding group versus 0% for the daily cow's milk formula group. Now, how good is per protocol exclusively breastfeeding? It's really good. So if you're able to do exclusive breastfeeding without a hint of cow's milk formula, then you have 0.7% in the medium blue developing cow's milk allergy versus 0 in the green. But that is not statistically significant, and possibly because the sample size wasn't big enough for that. But it's still really good. But the concern, again, from all this literature is this mixed feeding group. And I need to add that family history of atopy had no impact on these results. And basically, the authors of this study have concluded that any cow's milk formula exposure, if begun, has to be consistent, example daily, as occasional intermittent exposure increases risk. So that is just hot off the press. It's such strong level 1 evidence. How do we start discussing what are practical strategies towards approaching implementation of this data? Now, right off the bat, I want to declare that pediatric allergists and researchers in this space are not trying to undermine exclusive breastfeeding. We're concerned about the landscape. So the part that I presented earlier, that cow's milk allergy is potentially severe, even fatal, and there's a lack of awareness of risk factors for its development. So we have all these families just unknowingly doing these mixed feeding approaches and putting their babies at risk. And we can't ignore that mixed feeding occurs. It's a phenomenon occurring around the world. And so we have to move past the controversy of, of course, 100% of the population doing WHO recommendation is the best, but that's not the reality. And therefore, we have to focus on balancing benefits and risks. And so what is the reality of infant feeding in Canada? So it's better, right? So let's say in 2003, you had 17% exclusively breastfeeding for 6 months, increasing to 26% in 2011, increasing to 34% by this 2022 report. But what that means is you still have 62% doing mixed feeding. And again, the mixed feeding could be a mixed bag of all of those styles that we looked here in the COMET study. The one that I see the most, which is reflected in this data, is a few bottles in the first 2 days of life. So how can we start implementing towards the general population, towards parents? So to its credit, Food Allergy Canada has started that with the Eat Early, Eat Often document, which we've had for a few years now that I've had the pleasure of helping with as well. They revised recently to reflect the new CPS position statement, and it still has the terminology. If the cow's milk formula has been introduced, feed it regularly, at least 10 mLs, which is 2 teaspoons daily. But it also describes what do you do if you've been exclusively breastfeeding. Well, then at around 6 months of age, you start not homo milk, but you start yogurt or hard, grated cheese kind of approach, just to make it obvious. But that's really all that's out there. Other than that, there's essentially no guidance on cow's milk allergy prevention aimed at the general population in Canada. Everything's about peanut or egg. And so the other reason we've timed this webinar to now is just 2 weeks ago, we had this paper published in Pediatrics and Child Health, which is a commentary entitled Challenges Implementing Recent Recommendations of Daily Formula Supplementation for Allergy Prevention and Practical Real-World Options. So Denise Ridley, who's a dietitian and researcher in Edmonton, had reached out to me with concern about that terminology of that recommendation we had in that version of the CPS CSACI position statement that said at least 10 mLs a day. From the point of formula wastage perspective, so if a parent were to buy a tin and then only consume 10 mLs a day, you have to discard that mixture every day that you've made, let's say, the minimum volume, and then you would be, over the course of the tin's lifespan, end up pouring down the drain 90% of the mixtures. So you'd be wasting 90%. So from a pure monetary point of view, especially for lower income families, this is not feasible. And this was her concern, that when you look at randomized trials, that level 1 evidence, that holy grail that guidelines love so much, is that truly implementable in our healthcare systems? Quite often not. And that's why I personally am a real fan of real world evidence to supplement randomized trials, which is what we do actually in our oral immunotherapy research. We amass tons of real world data. But so because of this flaw in implementation, how can we work around that? And so what this commentary proposes is 3 unambiguous real world options. This is really the punchline of the talk. Option 1, exclusive breastfeeding, by far and away the best option for infant feeding. Make it very clear, we're not trying to undermine breastfeeding. However, for families that choose not or cannot exclusively breastfeed and choose to do mixed feeding, they have to know what the choices are ideally to be if they choose to intermittently supplement or regularly supplement. If it's intermittent supplementation, the paper argues for extensively hydrolyzed hypoallergenic formula, and I'll illustrate why on the next slide. If the decision is regular, such as 1 bottle a day supplementation, then it would be intact cow's milk formula based on all that evidence I showed you from CAT, SPADE, and COMET. So hopefully this is simple enough. And the question would be, how do we implement these 3 options in hospital newborn nurseries? That's one question. For example, in the first 2 days of life, how do we operationalize option 1 better? Can donor breast milk be made more available to those hungry infants in the first 2 days of life? Or can hypoallergenic formula be presented as an option in the newborn nursery for option 2? And why does option 2 exist? It's because when a systematic review of hydrolyzed, extensively hydrolyzed formula is done, it now is known that it doesn't prevent allergy. Okay, so all of these studies show that it crosses for the odds ratio 1 here, including for cow's milk sensitization and cow's milk allergy. So it doesn't prevent cow's milk allergy, very clear it doesn't, but the benefit of it crossing 1 is that it also means it doesn't increase risk of cow's milk allergy, whereas intact cow's milk protein given intermittently would, according to all those studies. So it's just not helping, but it's not doing harm either, which is why it's a benign option for those who choose intermittent supplementation. Now, I'm going to wrap up with a case which has been so pivotal. This is a patient of mine who I've met in the past couple of months. And I've entitled the case Infant with No Family History of Atopy, just to drive the point home that all those CATs, SPADE, COMET studies recruited standard risk infants, which is what this infant was as well. So this baby was born in Saskatoon, admitted to the ICU for 1 month for various issues. In the ICU, was fed and tolerated intact cow's milk formula. Upon discharge from hospital, mom breastfed exclusively, but was given no education about this whole topic. Maybe it's because the 6-year-old sister and the parents are not atopic, so there's not a hint of family history of atopy again. And the eczema didn't start until about 2 months of age. So in the NICU, there's just nothing to indicate to the healthcare staff that they should even mention cow's milk allergy prevention or food allergy prevention for that matter. There's no even hint that maybe we should talk about when to feed peanut non-choking. So then fast forward to 7 months of age, they moved to British Columbia. 10 months of age, is still exclusively is still breastfed, started some cereals and solids, but has first exposure to cow's milk protein in the form of ice cream. And that's the first exposure to cow's milk protein since that early month in the ICU, and has 2 episodes on separate days with immediate urticaria and vomiting. The physicians suspect cow's milk allergy and put it on our waiting list in our clinic. Then a month later is admitted to hospital for bronchiolitis, diagnosed with asthma. So starts getting, going through the allergic march. And despite cow's milk allergy being written in the hospital chart, is given Enfamil accidentally, which in retrospect seems to be partly because staff and parents were unaware that Enfamil is made with cow's milk protein. Infant has severe anaphylaxis, needs intubation, etc. And then I finally see soon afterwards, we triage to be seen sooner because our waiting list is 18 months. And then I confirm at around 11 months cow's milk allergy to this magnitude, where the specific IG is 31.5 and skin test is 13/7, and is now on my waiting list for oral immunotherapy. So some of my comments for this case is that cow's milk allergy prevention is not a Saskatoon problem. It's not a BC problem. It's a national problem. Every province has almost no awareness. And for this little boy, clinical decisions made in Saskatoon have now resulted in a lot of hospital-based care needed in BC, expensive care. And how common, therefore, is it for healthcare providers and parents to be unaware of something as simple that Enfamil is made with cow's milk protein? How early should parent education start? Should it be during pregnancy? Should it be in the newborn nursery? And how about healthcare staff education, such as what these myriad of brands of formula contain? Now, for example, that Enfamil is made with cow's milk protein, Similac, that hypoallergenic formula is a name such as Alimentum or Nutramigen. Could it be that healthcare staff are just not taught this anymore? Possibly. And so my take-home messages are that firstly, our aim should be cow's milk allergy prevention without undermining breastfeeding. I believe that it's possible to achieve both aims with the recognition simply that there is mixed feeding occurring frequently in Canada to a high proportion, that families need education during pregnancy and in the newborn nursery on the genesis of milk allergy and its prevention to make an informed decision on infant feeding. So how can we change the way feeding options are presented in the newborn nursery? And then lastly, in the era of shared decision-making, we should acknowledge that some families will place a higher priority on cow's milk allergy prevention than option 1, exclusive breastfeeding. And so these families should be supported with options 2 and 3. Because of the landscape that cow's milk allergy can be difficult to outgrow, is the leading cause of fatal anaphylaxis in school-age children, and access to oral immunotherapy, the topic of another day, is highly variable in pretty much every country. And so with that, I'd like to acknowledge everyone around the world who's contributed to all of the paradigm shifts for eat early and eat often, including Food Allergy Canada, and special thank you to my colleagues who have worked with me the most on position statements and changing practice. And thank you all for your attention. So with that, I'd like to turn it back to Jennifer and thank Food Allergy Canada again.
Great, thank you, Dr. Chan. I'd invite you to turn on your webcam and we'll go through some of the pre-submitted questions. So a lot of questions were actually answered. I could see that the pre-submitted questions, you covered that content really, really well. So thank you for that. But there are a few other ones that I'd like to, that weren't addressed that we can perhaps cover. So in the area of diagnosis, there has been some questions around, is there any movement or effort around diagnosing cow's milk allergy prenatally? Is there any path forward on that?
No, prenatal diagnosis is not, available clinically. And so you're talking about maybe taking, some sort of sample from the neonate, well, actually from the fetus. No. And in terms of the neonate, so after birth, as you could see from those studies, there's really no predisposing factors for a lot of these infants, such as family history. They're so young at birth that you don't see a manifestation such as eczema. So, if you basically you want to screen every infant somehow, it's not going to be cost effective. It's basically going to be impossible. And then if you want to stratify based on family history or some criteria like that, it's potentially going to miss a lot of infants. And then on top of that, the reason the CPS statement says that screening is not recommended in Canada is because the screening tests that we have available aren't even screening tests. So like that case I presented where had a big skin test size and a high specific IgE, those are confirmatory diagnostic tests. They're not screening tests. So
Right.
as it occurs right now, and this is like a topic that we've had other webinars for, there is no great screening test because of the risk of false positives with conventional tests. There are proposed more accurate tests such as basophil activation tests or epitope mapping tests that are still in the research phase. In the US, the epitope map has reached the market, but it's very expensive. For a single allergen, it's like thousands of dollars for the test, and it's not easily available in Canada. And because it's so expensive, it's not a screen either, because a fundamental criteria for a screen is it has to be cost effective. So yeah, unfortunately, we can't screen our way out of this pickle.
Okay, so let's move on to a question that's related to breastfeeding and its role in prevention. And you shared some research that kind of says there doesn't seem to be a role there. But if a mother is breastfeeding and has a diet that's high in dairy protein, might that be helpful for prevention?
So it likely won't be. There was a systematic review that was just published last year looking at the amount of food protein, and they looked at typical proteins like cow's milk protein, egg protein, peanut protein in human breast milk. And the way they approached that study was how much protein is there in terms of triggering an allergic reaction in an individual consuming that breast milk with diagnosed allergy to those foods. And they harnessed some of the eliciting dose literature that we've discussed at previous webinars and found that the amount of food protein in those studies was much lower than the ED01, which is the eliciting dose triggering reactions in 1% of the food allergic population. And so they estimated that the probability of triggering an allergic reaction in those infants would be less than, quite a bit, probably less than 1 in 1,000 for milk, egg, peanut, and wheat. So if it's not going to trigger a reaction in hardly any infants with diagnosed allergy to those foods, then we can extrapolate that it's probably not going to have any preventative effect either, because how are you going to tolerize an infant when it's really kind of quote unquote like homeopathic amounts in the breast milk. So and then not to mention beyond that, we actually don't have a clinical data that by mother consuming high amounts of those allergens in their own diet while breastfeeding, it's going to prevent allergy to peanut or cow's milk or whatever in the infant. In fact, the data has long-standing for decades been inconclusive, conflicting, poorly designed, and our guidelines therefore simply state, as was on that slide that I didn't really have the time to go into detail on, but basically manipulating a mother's diet during both pregnancy and breastfeeding has not been shown to modify food allergy outcomes in the infants.
Okay, great. So this question is around the role of probiotics. Is there a role? Do they have a protective effect prenatally or postnatally?
Yeah, so there's a lot of interest in the gut microbiome in general in medicine, which is very exciting. So across a wide variety of medical conditions, there's accumulating data that having the right mixture of bacteria in the gut is beneficial towards immune modulation and either prevention or treatment of a wide variety of immune related diseases. For allergic conditions specifically, we're getting more and more data like that as well. But when it comes to implementation, that's where there's still a bit of a gap in terms of, can you go to the store and purchase a mixture of probiotics to prevent allergic conditions or treat allergic conditions? Much of that type of data on the intervention, can you purchase it, is in the realm of atopic dermatitis for eczema. There, from a systematic review, is data that it may reduce the risk of eczema in young children. There is some data that it may be helpful for treatment of atopic dermatitis, and there are some products being marketed that way. In the food allergy prevention, there's a little bit of data that probiotics may reduce the risk of skin test positivity to cow's milk, but that hasn't gone as far to say, if you do a challenge, that you prevent cow's milk allergy per se. And so I would say that stay tuned. Maybe there will be data at some point on the specific type of probiotic that will prevent cow's milk allergy or peanut allergy or food allergy. We're really hopeful. We at our center are just embarking. We've just had ethics approval for a study where for our infants undergoing food immunotherapy. So such as that case I presented. So his next step in the journey is going to be milk OIT, oral immunotherapy. And what we're going to do is collect his stool right before he starts OIT, and then collect his stool at the end of the OIT journey and see how his gut microbiome changes and which bacteria are flourishing as we modulate his immune system with oral immunotherapy. And maybe that'll give us hints as to that perfect bacteria, quote unquote, that maybe should be supplemented early on.
Okay, terrific. So just wanted to note, we did get some questions that came in with regards to, when early introduction fails and kind of the role of milk bladders. And I know that that is a topic in of itself, and would welcome us scheduling something later in the year specifically to deal with the topic of milk bladders. So I just want to let the audience know that that's on our radar screen. We also I just want to make sure we go back to clarifying some of the key messages that some of the questions that are coming in. So around the guidance, and just to clarify that, from what you're saying is that the ultimate recommendation now is to avoid supplementation with cow's milk infant formula when not needed, but when temporary early supplementation is needed for medical reasons in the hospital, the thinking is that should be an extensively hydrolyzed infant formula.
So yes, that's what we were trying to make. It's simple and conveying 3 easy options. That is anchored again on that systematic review showing that cow's milk formula, that's the hypoallergenic formula, doesn't increase risk of developing cow's milk allergy. It's not, again, I don't want to get the message confused, because it's so confusing in general that hypoallergenic formula prevents cow's milk allergy, because it's not. It's been shown in that systematic review that it's just right neutral. It's right bang in the middle. So it's not going to help and it's not going to hurt. And so it's basically just a novel application of that data that's been out there for years now. It's from Bob Boyle and colleagues in the UK. Very, very rigorous systematic review that they did. And it's just us choosing to apply it, implement that data in a way that does the least harm. I struggle with that option in that right now, in my discussions at the hospital levels, it just seems like there's a little bit of confusion on how that family that knows that they're not going to be able to, not going to want to give formula regularly, how are they going to get access to that hypoallergenic formula in the nursery? Because every nursery, it seems, has different formulas available either through, the formulary, through a special section, formula room, versus just in the nursery, and those sort of details. And so I think to implement option 2 will be in every hospital and in every newborn nursery, really a careful discussion is of, are the staff aware of these options? Are the staff aware of the topic of cow's milk allergy prevention needing to be at least mentioned? Is there some kind of screen which doesn't involve a blood test, but some kind of screen which is more of what is your preference for choice of feeding? And so, yeah, that's where all the work is, I feel, in this sort of knowledge translation or implementation. It's like, what's the standard operating procedure for us to be able to implement this at the nursery level? So, yeah, I just want to make it clear that that option is a sort of novel application. Again, we're not trying to undermine breastfeeding. I hope that the exclusive breastfeeding rates continue to increase over time, and that we continue to stress option 1 whenever we have this conversation, which is exactly why we just released that paper that way, with option 1 being exclusive breastfeeding.
Right. Okay. So, and then one final clarifying question. So, for those who may be offering regular or intermittent infant formula while breastfeeding,
Yep.
is the CPS position statement then for at-risk only or for all infants?
Yeah, the statement is primarily for at-risk infants, but it does say, as do many of the guidelines, that those recommendations wouldn't do any harm for standard risk infants. And I would say, based on, especially this COMET study, that in the case of cow's milk allergy in particular, when at that very early time point of life, right after delivery, you haven't even had eczema expressed, because for peanut allergy, severe eczema is such a big risk factor in all the guidelines. But if you look at the timing of this topic, eczema doesn't start right when you're released out of the womb, right? So as a result, we're missing that high risk infant descriptor, and therefore, we have to be much less dogmatic about high risk versus low risk infant, and think that a standard risk infant is a pretty risky infant. I think you're going to have to think about more of a country rather than a family history in the case of cow's milk allergy. And by that, I mean a baby born in Canada versus a baby born in, you pick it, like an underdeveloped nation of your choice. So developed country versus underdeveloped. That's where you're going to have the higher risk versus lower risk.
Okay. Dr. Chan, this has been very informative, and we really appreciate you taking the time to take our audience through the studies, the research, and helping bring that to some 3 practical solutions going forward. So thank you, and we'll just wrap up with a few slides from Food Allergy Canada. So thank you very much.
You're very welcome. Yeah, it was a pleasure. Thank you for the opportunity.
All right, so for those of you who are looking for some more information related to today's discussion, there are some things that we would recommend you take a look at. First, we've got the Eat Early, Eat Often resource. It includes some practical tips on feeding babies early, recipes for different allergenic foods, and for more. And you can download that from foodallergycanada.ca/early intro. It's offered in both French and in English. Cow's milk protein allergy in babies, we did a webinar on that. That was really around understanding CMPA and how that is defined and how it's different from the IgE-mediated allergy that we spoke about today. It has some practical management strategies that families can follow, and you can watch it on foodallergycanada.ca/webinars. As a reminder, you'll get a short survey through GoToWebinar immediately after this, and it'll pop up on your screen. You'll also receive that survey in an email in the next hour, and we really would encourage you to take a moment to complete it because it helps us understand your information needs and where we need to fill in some gaps on the topic that we've talked about today. Also, we'd encourage you to take our webinar survey that tells us what other topics that you're interested in learning more about this year. It's only a 3-question survey, and it's open until February 17th. You can access that survey from links on our homepage at foodallergycanada.ca. Lastly, I'd encourage you to sign up to our allergy alerts safety service. You select the allergens that you want to stay updated on, and through this service, you'll receive information on food recalls, allergen changes from food manufacturing, and labeling updates. You can count on our allergy alert service to ensure you're kept informed on food safety issues that may impact you. Sign up at foodallergycanada.ca/subscribe. Today's webinar was supported by the Walter and Maria Schroeder Foundation, the Sean Delaney Memorial Golf Classic, and the Peanut Bureau of Canada, and it was made possible from donations from viewers like you. To help us continue this type of programming, we'd be delighted if you'd consider a donation today. You can visit foodallergycanada.ca/donate to learn more about the impact your donations make. And we'd also like to thank you for your participation in today's webinar. You can view a recording of this webinar at foodallergycanada.ca shortly. Please also share it with others who may benefit from this content. This now concludes our webinar.